Our next speaker now is Fidelma Lindsay. She has been in the role of CNM2 in endoscopy pre-assessment in the Adelaide and Meath Hospital in Tallaght since 2008. She graduated in 1985 as a registered general nurse from the Royal Victoria Hospital in Belfast and obtained her higher diploma in gastroenterology from UCD in 2005. She also for many years has been a member of the organising committee and a past chairperson for the GI Study Day for Nurses. And today, Fidelma is going to do her presentation to us here for endoscopy pre-assessment and the art of telephone nursing.
Hello everybody, I hope you can hear me. So today I'm going to talk about the endoscopy pre-assessment service I run in Tallaght University Hospital and the art of telephone nursing. So when I accepted the invitation to speak at this conference, I was sent an email explaining to me what the triage service involved, and a few items on that email actually struck me because I run a very similar service myself. So unusually nurses on a telephone system, the email said that these are nurses who never meet nor see their patients, and they're nurses whose skills lie in investigative questioning and telephone assessment. And that's exactly what my service involves as well. The difference being, of course, that the triage service covers a broad spectrum of medical issues, and my role is focused solely on endoscopy. So the endoscopy pre-assessment service in Tallaght University Hospital is myself. The vast majority of the work I do is through the telephone and contact with patients via the telephone. I work 25 hours a week. I end up speaking to between 20 to 24% of patients that would be listed for endoscopy procedures on any given week. We send patients a lot of information about the procedures, and on that information, certain categories of patients are invited to contact me, mostly relating to medications and people who have diabetes. So the telephone service is an adjunct to the written information that's received. The patients receive information and consent booklets, and there's one for every procedure that we do. They end up receiving quite a lot of literature, particularly if they're having a retrograde double balloon enteroscopy or colonoscopy, in which case they will also receive prescriptions for bowel preparation and instructions for bowel prep. So the aim of endoscopy pre-assessment is first and foremost to assist the patients make an informed consent about undergoing endoscopy procedures. And basically what that entails is trying to explain complex procedures in a way that patients will understand. I'm here to offer them reassurance. I'm here to act as a liaison between the department, between the doctors and the patients. And most of my work boils down to dealing with the practical issues, that being fasting times, medication, and the details about the bowel preparation itself. So for anybody who is not familiar with endoscopy procedures, that is a colonoscopy or a colonoscope picture. That's a €2 coin, just to give you some perspective. Procedures can differ in duration, anything from less than 10 minutes for a straightforward OGD or gastroscopy. Double balloon enteroscopy can last over 2 hours. We also undertake a wide range of therapeutic endoscopy procedures. And you'll see listed there EUSs with FNA, EMRs, that's endoscopic mucosal resection, placement of stents, chroma endoscopy, double and single balloon enteroscopy, and then capsule endoscopy is an option as well. So the problem of explaining these simple, not so simple camera tests has become much more complicated in recent years. The demand for endoscopy is increasing. 20 years ago, when I started in Tallaght University Hospital, we were doing nearly 4,000 procedures a year, and last year that had increased to over 7,500, with very little change in the resources available to us. The procedures are becoming increasingly complex, and I mentioned some of them in the previous slide. we sometimes forget how invasive these procedures can be. They not just involve the gastrointestinal tract, but of course can involve the lungs and bronchoscopy as well, and also the hepatobiliary system. So there is a potential for harm in endoscopy. Serious adverse events are very rare, but they can occur, and they can vary anything from respiratory arrest to perforation. So in an effort to present informed consent of a patient, as I said, we provide booklets for every procedure as pictured there. We have a legal obligation, of course, to inform our patients. We also know there are psychological benefits if patients are well informed about what they're going to experience in hospital before they actually arrive here. These booklets should arrive giving them time to consider, giving them time to ask questions. I'm here to answer questions. I will answer them honestly, and then we have to remember that the patient has the final say about whether they wish to proceed or not. So over to the practical issues that I'm presented with on a daily basis. Fasting is one of the major ones. Basically all patients who are going to receive intravenous sedation, and that's for the vast majority of endoscopy procedures, must be fasting for 12 hours from food and 4 hours from liquids. There is exceptions, of course, for the bowel preparation because they have to fast from food for a longer period of time, and I'll mention that in a later slide. And then sometimes doctors ask for an extended fast, and this can arise if patients have had gastroscopy and there has been food substances found in the stomach. They will then return for another gastroscopy, and I will contact them and we will discuss extending the food fast just to make allowances for that. During the fast, even from liquids, patients can take a minimum amount of water if they're taking essential medication during the liquid fast time, but just enough to swallow. They can rinse their mouth with water. And there is some debate about whether they should be allowed or can be allowed to chew gum or not. In lots of the research, it suggests it really presents very little harm, but here in Tallaght, we say no in our information. The medications in endoscopy, the ones that concern us basically fall into 4 categories. The first is essential medication. The second is medication that would have an impact perhaps on the success of the bowel prep. The third is medication that may have an impact on the effect of intravenous sedation. And the fourth are medications that might present a risk during the procedure. So I'll go through those now with you. So the essential medications, basically that really would only involve medication like anti-rejection medication if the patients have had previous transplant, if they're taking epilepsy drugs, or if they're on methadone. If a patient has a morning appointment and is still on these drugs, then we would advise them that they should take them as early as possible with the minimum amount of water to swallow, and a note of that would be made on the pre-assessment form. Medications that might impact the success of the bowel preparation, and the first one there is oral iron. Oral iron for lower endoscopy is an absolute no-no. It leaves a black coating on the inside of the bowel that not even the bowel preparation will shift. So people who are having retrograde double balloon enteroscopy or colonoscopy are asked to hold iron for 7 days, and then they can resume immediately after the procedure. It only has implications for those 2 procedures. So if they're taking a bowel preparation. The same for anti-diarrhea drugs. I would say to patients that if their bowel problem is diarrhea and they take anti-diarrhea drugs to control that, then it's generally not a major issue for us. But we would ask them not to take any anti-diarrhea drugs for 2 days before they're taking the bowel preparation. And basically that's to ensure that it doesn't counteract the intended effect of the prep itself. Laxatives, if I am speaking to a patient who is attending for investigations of constipation, I do ask them if they're taking laxatives and if the laxatives work for them, because they really should continue those up to the day before the bowel preparation. We wouldn't want them taking any general laxatives on the day that they're scheduled to start the bowel preparation itself, but up until that, absolutely, they should continue them. So with regard to medication that would have implications for the effect of the sedation on the patient, this would include medication for anxiety, depression, and methadone. For people who are taking these medications on a regular basis, it is likely that the standard dose of midazolam, the sedative, will not have the same effect as it would have for someone who doesn't take any type of medication like this. I do explain that to the patients. I make a note of it. I advise patients to bring it to the attention of the endoscopist, who will actually be given the sedation to them. The protocol advises that they start at the standard dose and then add to the sedative incrementally up to a maximum safe amount. If they've reached the maximum safe amount and the patient is still very uncomfortable, it's more likely that the procedure would be abandoned at that stage. But if the endoscopist is aware that patients take these type of medications in advance, they may start off with a higher dose of the midazolam to take account of that. If patients are on home oxygen or inhalers at home, of course, that needs to be noted as well, if they have any respiratory disease, because they will be very cautious. The doctors will be very cautious in administering intravenous sedation to these patients. So the medications then that would create a heightened risk during endoscopy is the anticoagulants, of course, and a lot of anticoagulants around at the moment. A lot of people with newly diagnosed atrial fibrillation on anticoagulants. Some of the antiplatelets, and then of course the diabetic drugs, because these patients have to fast. So just first with diabetes, we advise diabetics with reference to our own medicines guide here. And in the shaded area in blue, this is what the medicines guide says for this year in Tallaght Hospital. When I'm speaking to people with diabetes, I'm really focusing on their diabetic safety. So I will ask them what their current blood glucose level range is, just to make sure that the diabetes is stable. I'll see if they have had a recent HbA1c result here in Tallaght and check what that is. During fasting times from food, patients who have diabetes are asked to check their blood glucose level 4 hourly, and they're advised that they should take remedial action if at any time the blood sugar reading is 4.0 or below, or if at any stage they develop any of the symptoms which indicate that the blood sugar is going too low, and I will review what those symptoms are with them. If patients report that their diabetes is unstable, or if they are type 1 diabetics, they are referred to our diabetic CNS service for advice on what to do about their medication. Always the emphasis is on the primacy of stable blood sugar over absolute fast. So now on to what patients refer to as the blood thinners. We follow the European Society of Gastrointestinal Endoscopy guidelines, and basically anticoagulants and antiplatelets are held only on the written instruction of a doctor, either the endoscopist or the consultant that the patient is listed to. The assessment is made about the anticoagulants on the balance of risk. So the risk of stopping the anticoagulant or antiplatelet, and any risk that might be anticipated during the procedure. By and large, first option, these patients are all left on their medication unless we know for certain that there are, say, polyps in the bowel, or that there are certain therapeutic interventions that's required, say if the patient is coming for an ERCP and will require an intervention to enlarge the duct there during ERCP. So aspirin 75 is exempted from exclusion. All patients are advised that they can continue aspirin 75. There are extremely rare incidences where we might ask the patients to hold the aspirin, but in the vast majority of cases, there's just continued. When they're deciding on the anticoagulant and antiplatelets, we're looking at the indication for the procedure, of course, as I mentioned, but also the indication for the drug. So if you have a patient on dual antiplatelet therapy who has had cardiac stents placed in the last few months, then we would not be stopping that medication. There would be a review by the endoscopist in consultation with the cardiologist if necessary. These procedures would just go ahead if they are absolutely necessary. Otherwise, they'll defer until it is regarded as safe, or at least reasonably safe, to hold one of the antiplatelet drugs. And of course, if the patient has had previous endoscopies, say previous colonoscopies, and they've had multiple polyps removed from the bowel, then chances are they're going to be more. So we would look seriously at holding the medications in those circumstances. We always emphasize to patients that even though we have taken account of the balance of risk and made the judgment to hold medications on that basis, we cannot make that risk nil. We want to inform them, be honest, as I said, without alarming them. So now on to everybody's favorite topic, bowel preparations. So there's a huge difference in the theory and practice when it comes to bowel preparation. A wide variety of products on the market. Our default bowel preparation at the moment is MoviPrep, but the others are options for us. Even though there is a wide variety of products, the mechanism of action for all bowel preparations is the same. They're all stimulants. They're all designed to have the same effect. So I have patients who ask me if they could take something that would be a little bit gentler on the system. I'm afraid there's nothing like that at the moment. Some, as I said, easier to take, but all have the same effect. These are prescribed drugs. They are paid for by the patients. They're not paid, they're not covered by any scheme at the moment. And they do, there is a wide variety of price. So say Picolax would be, it's the oldest product on the market. It would come in around €10. And then you can go right up to the MoviPrep, which can be 24, 25 euros. So it is an expense. Therefore, it is important that we recognize that they don't always work. The rate of per bowel preparation in the research literature is anything from 18 to 35%, and there's a whole range of levels of per prep in that, from the perfectly clean bowel that you will see there on the left to the terrible bowel prep, which you can see on the right. So if patients are returning from having had a colonoscopy procedure or retrograde double balloon enteroscopy, and the prep has turned out to be terrible and the procedure have to be abandoned, and even in some cases when they have managed to negotiate all of the large bowel, say in a colonoscopy right around to the cecum, if the doctors aren't happy that they have been able to see enough of the mucosa of the bowel, they will refer the patient back for a repeat colonoscopy procedure. The costs of per prep really are they have a large impact on the costs to the health service. There is the cost of missed polyps, of course. If we miss polyps because the bowel preparation wasn't good enough, there is a potential that that is going to cause serious problems in the future for the patient. There can be delays in diagnosis because the patient has to have another colonoscopy because the previous bowel preparation hadn't worked well enough for them. And of course, this all uses the finite resources we have in the endoscopy department. There is a financial cost to the patient because they have to buy a second bowel preparation. There's an increased risk to the patient if the bowel isn't clean, because the doctors can be proceeding with the endoscopy procedure in a situation where they can't perfectly see the lumen of the bowel. if as in the previous slide, the bowel preparation is as bad as that would be abandoned. And then, of course, you've got increased anxiety for the patients who have come into the hospital for this test, thinking they're going to learn something about what their medical problems are. And then it turns out that there's no answer for them at all, and they just have to come back for the procedure. Some of the factors in poor bowel preparation that the research has uncovered, some medications are significant, some antidepressants, people who are on diabetic medication, because diabetes, the fact that the patient has diabetes increases their risk of poor bowel preparation. History of constipation, of course, hardly any surprise there. Increasing age, males, for some reason, and patients who are having colonoscopies as inpatients. And that, of course, would be obvious as well. Lack of privacy, shared bathrooms. They may be in hospital for another reason entirely. They're not well. So here we try and avoid inpatient colonoscopy if we can. They might have a gastroscopy done as an inpatient, and then they're discharged and referred for outpatient colonoscopy. So when I come across someone who has previous history of poor bowel preparation, the first thing I do is assess. So that involves asking them questions about their bowel pattern, about how bad the constipation might be, or if they have diarrhea, if they take antidiarrheal medication. If they use laxatives, if they've used laxatives in the past that work for them, if they're taking them regularly. And then I individualize the advice to the patient. Our patients all receive information about low residue diet. Now, the research into the effect of low residue diet and improving bowel preparation is not overwhelming, but there is some research papers that suggest that it does make a difference to how effective the bowel preparation is. The European Society of Gastroenterology in their directions with bowel preparation recommend that patients have low residue diet, and our patients are advised to follow it for 2 days in advance of taking the bowel preparation. Of course, then we have the option of adding in general laxatives if that seems like a good option. Movicol is one that the doctors tend to opt for these days, and that gives us the chance, if we about 5 days in advance of taking bowel preparation, we can advise the patient to take something like Movicol and increase the dose over a number of days to try and relieve any constipation that is there before they even take the bowel preparation as well. Because as I tell all the patients about bowel preparation, the intent of bowel preparation isn't to just empty the bowel, it's to really get it spick and span clean as you saw in the picture previously. And that's actually very, very hard to do. One piece of advice that I do give to patients is to consider delaying the start of the bowel preparation. As we noted, the amount of per bowel preparation that is returned from colonoscopy can be significant numbers. And there has been an awful lot of research done into how they might overcome this problem with getting the bowel completely clean. So various things have been tried, various bowel preps have been tried, and the only thing in the research that seems to work, that has worked in all the studies conducted in it, is that you take some of the bowel preparation as close to the time of your colonoscopy as possible. So if I have a reasonably healthy, reasonably young person, I will basically ask them to take the prep in the middle of the night. They're not going to get any sleep, of course, but on the upside, it does improve the chances of the bowel preparation working. And in the cases where I have advised patients to do that, it certainly does seem to work. If all else fails and colonoscopy doesn't work, we can proceed to a CT colonography with fecal tagging, and that would at least allow us to rule out any significant bowel pathology for these patients. So I was given a list of, in the email, a list of the frequently asked questions that the triage nurses encounter. And I have to say, by and large, they're all the questions that I get myself as well. And the first one, and the one that occurs most frequently, is, will I be knocked out? And the answer to that is no. I mean, usually I'm not that blunt to patients. What I say to patients is that if you're saying to me you wish to be knocked out, I interpret that as medically unconscious. And since you do not receive a general anaesthetic, and general anaesthetic drugs are not available for endoscopy in Tallaght University Hospital, then you won't be knocked out. But sedation is a very good drug to use in endoscopy. It is designed to relax the patient. It's used in combination with pain relief drugs. For colonoscopy, retrograde, double balloon, an opiate is also given, usually fentanyl. So that adds to that nice relaxed feeling. The emphasis for the patient, what I advise the patient, is every effort is made to minimize any discomfort. So we can use antispasmodic drugs as well. And I do like to reassure the patient that they are entitled to withdraw consent at any time and ask for the procedure to be stopped. Second question then is, do I have to take all of the bowel prep? And the short answer to that is generally yes. In very rare circumstances, if someone had a very high stoma, we might advise them to take sufficient bowel preparation until they're running clear. But in my experience, bowel preparation really has to be completed. The medical information with the bowel preparation actually gives them the same direction. You take the bowel preparation until the bowel is running clear, but that really doesn't necessarily mean that the bowel is going to be completely clean during endoscopy. Certainly they need to take, say in the case of Movicol, they need to take at least half of the second litre if they can. So in the most situations, I would encourage people to complete the bowel preparation. But then you'd say, what if the prep is causing me to vomit? Should I continue? And that is a no. Like any drug, if it causes you to be sick, causes you to vomit, you should stop taking it. As well as that, if you're not able to keep the bowel preparation down, there's no chance of it actually getting to the large bowel, which is where it needs to get to actually do its work. So no, stop taking the bowel preparation and contact the department. I could not take all of the bowel preparation. Should I still attend? I would generally ask how much they were able to take, and as I said earlier, what effect that has had. So if they're just passing liquid now, if they've taken 2/3 of it, then come in and let the doctor assess them. If it's anything less than that, if they've just had 1 litre of Movi prep or just a fraction of the bowel preparation and they couldn't take any more, if they're still passing formed bowel motions, then the chances that the colonoscopy is going to be completed is very low. So they just contact the department in those circumstances. How quickly does the prep work? This varies from person to person and from prep to prep. Say they would need to have at least taken half of it usually before the prep starts to work. It would be very unusual if it hasn't started to work before they get to the second half. I would say to patients that once it does start to work, the worst of it, so the worst of the diarrhea, is usually over the following 2 to 3 hours. It does tend to settle down then, and most people manage to get a reasonable night's sleep before they come in for endoscopy. So if a patient says to you, I forgot to start it on time, is it too late? Bearing in mind what I said earlier about the research suggesting that the closer to the time of your colonoscopy you actually take the bowel preparation, the better the chance that the bowel is actually going to be clean, then I would encourage them to start it as soon as possible. They should keep to the same time schedule. So say with Movi Prep, if you're coming for a morning appointment, our instruction leaflet says that you should start the first litre at 5 and the second litre at 8. That's 3 hours apart. So if you're only starting the first litre at 9, then you shouldn't start the second litre till midnight. Okay, and then just follow the schedule on like that. if the patient asks, should I take medication on the day of the prep? Yes, they are permitted to take their usual medication unless we have asked them specifically to hold medication like iron, diabetic medication, or anticoagulant or antiplatelet. But yes, they can take their other medication as scheduled, but not while drinking the bowel preparation. And for 1 hour either side. There's no huge evidence to suggest that bowel preparation actually interferes with the absorption of drugs, but it is a precautionary recommendation that they don't try and take tablets while they're still drinking the bowel preparation. Although who would do that? I don't know. And for 1 hour either side of the preparation. If they are asking, can they take their medication on the morning of the procedure? Our literature at the moment says that if you're coming before 11 a.m., then you should not take morning medication. Exceptions to that would be nebulizers, inhalers, or any of the essential medication. And as I said, they should take that as early as possible if they wish to take it with a sip of water to swallow. If their appointment is after 11 a.m., yes, then they can take their morning medication as usual before they begin their complete fast. If in doubt, they can call and talk to me or call and speak to the endoscopy unit itself. I was asked to give some information on the post-endoscopy advice that patients are given. This is not an area generally that I cover, but patients are spoken to by the endoscopist after the procedures. They are given some information as to how the procedure has gone and what the outcome has been. But because of the amnesic effects of midazolam, patients won't always remember. If they have someone with them, the person who has come to collect them from the unit, then that's a better situation, but it doesn't always happen that way. They are given discharge leaflets for every procedure. They're also given a copy of their endoscopy report for their own records. So that would be a way of actually checking what has gone on during the endoscopy procedure itself, which may help guide your advice to these patients if they're asking about something after having had an endoscopy procedure done. So there are just some common problems post-endoscopy. If they've had polyps removed or hemorrhoids treated, they may have a little spotting of blood, but really that should really only be on the day of the test and nothing beyond spotting. They may still be experiencing some pain, some discomfort, bloating, but if their tummy is soft and if they're passing flatus, this is likely just air that has been left behind during the endoscopy process. All endoscopy procedures, the doctors will introduce air, and that's to allow them to visualize the gastrointestinal mucosa. Now, every effort is made to withdraw that air on the way out, but because of the structure of particularly the large bowel, some air can get left behind, and then this gives rise to this feeling of bloating and discomfort. If they've no temperature, that's significant. Just to point out that sedation really should have no lasting respiratory effects. So if patients are reporting significant respiratory problems post-sedation, then they should probably seek a medical opinion on that. They should certainly seek medical opinion if there is bleeding, if that is large volume, if it's frank blood, if it's days after the procedure, if they're complaining of melena, if they're vomiting or coughing blood. Okay, if they're reporting pain, then try and scale it. Ask them 1 to 10 how bad it is. Ask them, is their tummy swollen and firm? If they're not passing flatus, and if they have referred pain up into their shoulders. If the report indicates that they've had any therapeutic intervention at all, then that is possibly a medical emergency. Particularly if they have a temperature as well, and if they're reporting difficulty with breathing. That pertains to any endoscopy procedure, but particularly bronchoscopy or upper GI scopes. So just a few pictures to end. The one down on the left, that's diverticulosis, very common. The upper ones are little healing ulcers in the stomach. You can see the little white patches, and the lower one on the right is a colonic tumor, just to give you some idea of what an endoscopy image looks like. So that's it. Thank you very much for listening to me, and I'm happy to take any questions.
Thank you so much for that, Fidelma. That was very, very interesting and put you off all those scopes. I just have a few little questions here. It's just really, you mentioned kind of on the vomiting, because people do ring in the out of hours, people who have, you know, they're vomiting and they're taking their bowel preps.
Yes.
And is there any kind of, you know, is there anything that you could actually give them, you know, when they ring, or is it just stop it, like you said, like stop taking the prep, or can they be given maybe, you know, an antiemetic or something like that?
Yeah, I mean, there would be no reason not to take an antiemetic, although we would find that if the prep is causing them to vomit, that will settle down quite quickly after the prep is stopped. If they're continuing to vomit, they can certainly take an antiemetic, but there would be a slight chance that they're having a reaction to the bowel preparation. So if the vomiting is excessive, then they certainly should seek a medical opinion about that.
Thank you. Another question here. Patients who ring the out of hours with questions what pain relief they can take during bowel prep. You know, sometimes they're complaining of pain kind of when they're taking that. Would you suggest something like, say, soluble paracetamol, Lemsip, or anything like, you know, effervescent like that, or is it just no?
Yeah, generally, if patients have pain during bowel preparation, it usually is a symptom that has been part of the indication for the procedure in the first place. So whatever medication that they would generally take, whatever analgesia they would generally take for relief of pain in those circumstances is fine by us. When it comes to bowel preparation and pain, the most obvious thing would be an antispasmodic, because since the bowel preparations are stimulants, this is what it has done to the bowel. It has overstimulated the bowel. So antispasmodics, if they have one, would be the most obvious one. But if they don't have that, then whatever pain relief medication has worked for them in the past.
Brilliant, brilliant. And just a quick one there regarding COVID and that. Do you see any increase in patients with inflammation of the gastric tract, you know, after having COVID, or is that not come to the fore with you yet?
No, I haven't come across that yet, but even though I run the Preassessment, and I haven't encountered any referrals actually either. But even though I run the Preassessment service, on the day-to-day working of the endoscopy lists, I'm not directly involved in that. But that's an interesting question. I actually will be asking the sisters in endoscopy if they have come across anything like that. But I haven't seen anything on any referrals to suggest that patients are coming to us as a consequence of COVID.
Well, that's all I have, and thank you so much for that. That was excellent. Thank you.
You're very welcome. I hope you have a lovely day for the rest of the day, everyone. Thank you.
Oh, thank you very much, Fidelma. It's always very interesting to hear from other nursing disciplines that work over the phone as well. Thank you for that.